Good afternoon, everyone. Thank you so much for joining us today. We are presenting a webinar for the National Cancer Institute's Community Cancer Centers Program Navigation Assessment Tool. My name is Shira Morales, and I'm the Project Manager for Healthcare Professional Education at the GW Cancer Institute. Before we get started, I would like to take a few minutes to just go over some housekeeping remarks. We're going to go ahead and ask everyone to keep their phones on mute to avoid any background noise and any disruption during the program. And also, just so you're aware, today's program is being recorded. We're going to be using the Q&A feature for this webinar. So you're going to see the Q&A box at the bottom right hand of your screen. So if at any time during the presentation you have a question, please type it in and we will address it during the Q&A portion at the end of this webinar. The questions will be anonymous and I will repeat the question. So we will take questions at the end of the presentation, but feel free to write questions in the Q&A box as we go, and we will make sure to answer them during the time allotted. We are going to also be using a chat box feature, which is on the top right side of your screen, and you can use that chat box to interact with each other. So because we're going to be talking throughout the presentation, we probably won't be able to keep up with the chat. So just make sure that if you want to ask a question, you go ahead and use that Q&A box on the bottom right. And as a note before we get started, we will be sending out a PDF of the slides and a link to the archived webinar to all the participants today. The recording will be also archived on our website along with our previous webinars. So I'm just going to take a quick minute to review today's agenda. I'm going to go ahead and provide a brief overview of the Center for the Advancement of Cancer Survivorship Navigation and Policy. Peggy Thomas and Ms. Kathleen Gamblin will provide a presentation on the NCCCP Navigation Assessment Tool. And we will conclude the webinar with a participant Q&A, and we'll do so again through that Q&A feature on the bottom right of your screen. So I'm going to provide a brief overview of the Center for the Advancement of Cancer Survivorship Navigation and Policy, which brings you today's webinar. The Center for the Advancement of Cancer Survivorship Navigation and Policy, which we affectionately call CA-SNAP, was created in 2009 through a generous grant from the Pfizer Global Health Partnerships Program. Now, the mission of the center is to advance cancer survivorship and patient navigation efforts locally and nationally through education and training, policy analysis, outreach, and research. The center offers survivorship and navigation resources that are available online at our website and through our monthly e-newsletter. Additional material is sent through our CA-SNAP listserv to over 2,400 subscribers. We write white papers, we create case studies, and we work cooperatively with other health organizations to really advance patient-centered care. We also share summaries of our meetings and roundtables that we have hosted to catalyze patient navigation, cancer survivorship, and patient-centered care initiatives. Through CA-SNAP, we're offering several trainings. We were recently awarded funding from the Centers for Disease Control and Prevention that will really help us translate our existing in-person trainings to an online format to make them available at no charge for participants. We will start with our executive training on navigation and survivorship, which is a nuts and bolts training for building and sustaining navigation and survivorship programs. And we will be launching this program really soon. We're also developing a competency-based patient navigator training that will be available through our online academy, and we are full steam ahead working on that as well. So if there are any topics that you would like to know more about, please let us know. Our email is listed on the screen at casnp@gwu.edu. So here's some more information about our CA-SNAP resources, and you can visit our website to see webinars and to see our reports. We also encourage you to check out our free Cancer Survivorship e-learning series for primary care providers at the link on the screen, and that's cancersurvivorshipcentereducation.org. And we have had a lot of oncology professionals complete it, and they find it very useful. We recently launched a new module on prostate cancer survivorship care guidelines, so be sure to check those out. We also launched a new website for comprehensive cancer control programs. This site includes our resource repository where users can really search for and access comprehensive cancer control resources produced not only by the GW Cancer Institute, but also by state comprehensive cancer control programs and their partners, cancer control coalitions, and other stakeholders. And you can access this website again as seen on the screen, www.cancercontroltap.org. Now, again, just a friendly reminder that following this webinar, we will be sending you an email with today's recording and the slides. You will be automatically redirected to an evaluation survey to provide feedback on today's webinar at the conclusion of the presentation, and we look forward to hearing you so that we can better serve your needs. So I would like to introduce today's presenters. Peggy Thomas has been a nurse navigator for 15 years. She currently works at Penrose Cancer Center as an outreach nurse navigator. She's had a wide range of experience developing a breast navigation program, collaborating with local breast organizations to increase screening, presenting locally and nationally, co-authoring a chapter of the Oncology Nursing Society's navigation book, and developing the role of the outreach nurse navigator. Ms. Kathleen Gamblin began working in patient navigation as a thoracic oncology nurse navigator in 2006. Kathleen was co-editor of the first book on oncology nurse navigation, Oncology Nurse Navigation, Delivering Patient-Centered Care Across the Continuum, and co-authored 2 chapters of the book, Documentation and Patient Navigation Software and Navigation Resources. In addition, she was one of the 3 co-chairs for the Patient Navigation Working Group for the National Cancer Institute's Community Cancer Center Program's Medical Advisory Board member for the Colon Cancer Alliance and co-founder of the Georgia Oncology Nurse Navigation Network. Wow, ladies, thank you so much for joining us today.
Thank you. You guys hear me?
Yes, ma'am. If you can go ahead and turn up your audio just a little bit.
Okay. There we go. So
Okay.
Kathleen and I are going to talk about the NCI Community Cancer Centers program and the Navigation Assessment Tool. We were both the co-chairs of the program towards the end. The National Cancer Institute Community Cancer Center program was launched to improve quality of care and enhance the level of cancer research taking place in the community. So really what they wanted to see was, could we replicate in a community setting what is done at the big NCI institutes? The program piloted in 2007 and started with 16 hospitals, and then in 2009 it increased to 30 hospitals, and then in 2012 it continued for an additional 2 years with 21 hospitals. Now this is kind of a busy slide, and all it's really trying to show you is that we had hospitals that were rural, we had suburban, we had urban centers, we were all across the United States. We had challenges for trying to meet because we had all the different time zones, including Hawaii. So it made it a very interesting group. All of the groups were at different places. Some had fully developed navigation programs, some were just starting, and some had none. So it was a learning experience for all of us with where we were and the different community settings. The whole goal was to reduce cancer healthcare disparities. So each group that applied for a position in this basically determined what their own disparate group was, whether it was being rural outreach, Latino, African American, Native American. So each group was looking at things a little differently. We were to increase patient participation in clinical trials, especially with whatever our disparate population was, improve quality of cancer care, enhance cancer survivorship and palliative care services, which really we did a lot of work in that, expand the use of electronic health records, and promote high-quality biospecimens. There were many subcommittees with the NCCCP, and one of them was the Quality of Care Subcommittee, and it was basically to help develop multidisciplinary care programs. In 2009, we realized that navigation was a big part of quality of care. We also realized that there was no standardization in navigation. No one knew where to start. Some programs were well developed, some were just starting. So the Patient Navigation Working Group was formed. It reviewed navigation programs and best practices. So some of the presentations we did was on what are the different job descriptions? Were you doing patient navigation with lay navigators, social workers, nurses? What was working good in your community? What kind of acuity systems had you developed? What kind of outreach had you looked at? Some of the marketing, the referral basis, how you were interacting in MDCs, reporting and tracking systems, and how navigation helped access patients to clinical trials. So these were all works in process, and it was very interesting seeing how all of the programs developed over the years. There was a white paper created on how the NCCCP was using patient navigation to help reduce cancer disparities. We looked at the different populations we were serving and the uniqueness depending upon where we were, what our capabilities were. And finally, because there were no core competencies at that point, it really became how to create a navigation self-assessment tool. And that article was published in 2012 by then several of the co-chairs of the navigation program, which was at that point Jay, Judy, and Pat. So why did we feel we needed the navigation assessment tool? We wanted to have some kind of formal way to look at navigation programs, to see whether we were improving, how navigation was helping patients decrease their distress, and also to find out about return on investment. So how could we reduce financial stress on the system? It was also a way to research our programs to see whether we were growing and develop. It explained our focus and outcomes. It was not to, however, show us how to develop a program. It couldn't standardize processes because, as we all know when we're in navigation, just because you've seen one program doesn't mean it explains how the next program is going to be done. All the needs are different in the different communities, who your stakeholders are is different, and how you're going to develop your program is going to depend on your local needs. And it's not addressed there to say how effective is your program, but just to see are you growing and which areas are important to you. So we came up with 16 areas that we assessed. Kathleen will go over those in a minute here, but we looked at who are your stakeholders, who are your community partners, what kind of acuity system did you have, what kind of quality improvement are you doing, how are you marketing your program, and down the line. All 30 of the participating cancer centers at that point graded themselves on a score of 1 to 5, with 1 being very basic and 5 being the top. And they identified where we were on this. And as a group, we had some that were very outstanding in the beginning, but most of us were beginners, and we improved along the line. So to implement it, you need to determine the goals for your program. Each program is going to be a little different. You need to look at your system. Do you have employed physician versus private practice? How many patients do you actually treat? What is your patient population? How many are locally? How many have to come in? The 16 areas of assessment are not supposed to go where you start with where are my stakeholders, once I've developed that, now I'm going to go do my community partners, but it's more to look at your overall program. Some assessment areas will fit into where your goals are right away. Others may not be as significant to you due to your patient population, the financial resources of your program. One of the key things we found in the beginning, and I will go over that more in the end, is you need to have many, many people grade you on the assessment areas sometimes how we see ourselves and how some of our stakeholders see how we're performing in a certain area may be very different. What their needs are is different. So really it comes down to where is your program, who are your stakeholders, and how do they judge your program. One of the things, once everyone had graded themselves and figured out where their programs were, we began to make small improvements. Most of the programs picked 1 or 2 areas, maybe 3, to improve upon so that they could then move forward. Kathleen's going to take over now and kind of start with the different assessment areas.
Thank you. Oh, I think I went one too far. I think the first thing I'd like to start with is I can't stress enough that this is not a tool in which level 5 is success, because as Peggy said, there are some areas that may not be as important to your system. There may be areas where the resources don't exist to get you to a level 5. So this is really just based upon your individual program. The first assessment area that we really looked at was key stakeholders, and these are the people that are essential to making your program work. So looking at the navigators and the cancer center staff, administration, and then physician involvement. And I have to say that, buy-in from the healthcare providers is central to the long-term success and survival of a program. I also think that the cancer center administration is key. Having someone who, having the administration be supportive of navigation and the goals that you're working toward is going to be critical. And then finally, in the physician involvement piece, really looking not just at the employed physicians of a health system or a hospital, but also looking at those non-employed physicians and looking at all of the various specialties, because their buy-in will be important as well. And then looking at someone that can be a program champion for you. So you want someone who's knowledgeable about healthcare barriers in your area, who's knowledgeable and has been educated about navigation and can advocate for navigation, methods to address gaps in services, physician and patient satisfaction, and then ways to promote positive impact navigation has for patients and healthcare system. I think within our program, all the difference has been made as we started looking at it, at putting a supervisor in place who is in charge of navigation and really looking out for the strategic growth of navigation. That's one of the things that we've seen in centers across the country is when you have navigators reporting to different people, sometimes there's a fragmentation. So really getting that physician champion and kind of that lead person who can oversee the program and kind of work to help grow it. And then looking at the community partnerships. So as we look at community partnerships, those entities that are within and outside of a program that provides support for patients along the continuum of care. And so we look at those things that are available to us. When our program started, we realized that there were a lot of resources that our hospital had that we weren't taking advantage of because people didn't know about them. So really helping to pull those partnerships together, and then looking at the partnerships that are outside of the hospital. So patients are facing so many barriers. They have informational barriers, the educational materials that they receive, the information that they're getting. Social barriers, they may live alone, they may be far from family. Physical, patients are diagnosed and they have other comorbidities along with their diagnosis. Looking at the emotional impact of a cancer diagnosis on that patient and their family. Psychological, because you get cancer does not preclude you from having a mental health diagnosis previously, and so what we see is that frequently we're treating patients that are bipolar or have depression or have other issues that need to be addressed along with their cancer treatment. Looking at the spiritual realm and what impact does this have on them, and finally the practical needs, which when you talk about navigation is frequently where people think of us. So looking at the housing and transportation and all of those things that go into it. So as we start with the level 1 kind of navigation, the navigator working within that hospital and within those departments, maybe outside of the cancer area, but within our own hospital. And then working all the way up through 5 where we talk about formal connections to national, local, state organizations where you may have official ties with them. We share a navigator with the American Cancer Society who has generously partnered with us, and so we have a great partnership with them and a working relationship with them here at our facility. Assessment Area 3, acuity system and risk factor identification. I think this is something that we initially struggled with. It's really that ability to determine the appropriate level of care and intervention based on patient need and disease process. It really is necessary to kind of assess the navigator workload, to evaluate navigation assignments based on the measured workload, and then provide the navigator support. So as you're looking at the navigator workload, you'll frequently find that a breast navigator can take on more patients than, say, a head and neck or a neuro navigator, where the needs may be a little more complex of those patients. Also looking at what kind of support does that navigator need to do their job. So when we're looking at the thoracic navigation, as they're working with CT screening patients, what we found is that there was an increased need for some admin support, that she could not do that. And so we figured that initially into her workload, and then we're able to make the case that we needed some admin assistance to help her do that. Currently, there's not an evidence-based system for acuity for navigation. So facilities have come up with their own. Billings in Montana has one that you can find on the ACCC site, and they kind of broke down what they were doing for their patients and then did an acuity model. One of the interesting projects that's going on right now is the Deep South Cancer Navigation Network, and they got a Healthcare Innovation Challenge Grant Award from the Center for Medicare and Medicaid Innovation. And they have put a lay navigation program into place in 9 facilities across the South. And they've looked at those things that frequently send people to the hospital and why people are being hospitalized and sent to the emergency room. So they're working with patients that are 65 and older. They're working with patients with certain comorbidities, patients that are on certain medications. So one of the things we've done in our facility is as we're identifying patients in our navigation program, those are some of the things we're now looking for. You know, we're in a metro area, so we're looking at patients that are coming in and driving long distances. We're looking at those patients that are 65 and older, those patients that have comorbidities, are on high-risk medications such as insulin, anticoagulants, things such as that, and identifying those patients as possibly needing a higher touch point. And then as we look at quality improvement, which is so very important. So one of the primary goals of navigation is to overcome barriers to timely and have patients reach quality care. So 4 measurable outcomes identified in navigation are reducing that time to initiation, improving the time to diagnosis, reducing time to initiation of cancer treatment, increasing patient satisfaction with care, and then improving cost effectiveness. So we do know that we can improve that time to diagnosis. There was a multidisciplinary lung clinic, and through the work of the thoracic navigator, they were able to take that diagnosis to treatment time from 52 days initially down to 12. And that was really with coordination of care and the assistance that they were able to give. Looking at reducing that time to initiation of cancer treatment, so really ensuring that these patients are following up in a timely manner, that they know what their next step is. Navigation can be very, very assistive in that area. And so as we look once again at that matrix across those 4 levels, we would say that our level 1, there are no quality improvement measures in place. And then working up through that level 5 where there's multiple QI initiatives in place where we're monitoring our success and our progress. I think when you begin a program, most of us start at about a level 1. And then as you get farther into it, you begin to initiate those quality initiatives where you're seeing areas for improvement that you can go ahead and do. You know, currently navigation services are not billable, so there really is that growing need to identify measures of sustainability and developing those quality improvement measures that will document the worth of navigation. And some of those are patient satisfaction. And so looking at patient satisfaction surveys, is that something that you can go ahead and incorporate into something you're already doing with patient satisfaction? Is it something that can be brand new? We're currently working on a constant contact survey that will go out to our patients as they're finishing treatment for them to be able to kind of rate our navigation program and how helpful and assistive that was to them. And then looking at marketing. So marketing is both internal and external. So when we begin the program, we really need to educate our internal customers. So we are going to do that, by going to our physicians and our healthcare staff. I would argue that your healthcare staff is probably more important than even your physicians, because the people that work for your physicians are the people that are going to help those referrals come in. And so focusing on going out and getting the word out. And initially, most people begin by word of mouth. I think one of the a plug for the executive training on navigation and survivorship was one of the activities they had us do was an elevator speech, was just that quick, brief speech about navigation. And so catching physicians and healthcare people in the hallway and being able to give them that elevator speech. We don't often have a long time to go into their offices and talk to them, but having that at the ready was key for us. And then looking at our external customers. So once we started to get physicians and you get that healthcare staff on board, then looking at how do you bring in patients and families. And so beginning with print materials, going out to health fairs and screenings. And so as we begin, in the beginning, our level 1 really is kind of that word of mouth as we're talking about navigation, and then moving up through the level 5 using multiple sources to do the marketing for our program. Assessment Area 6 is the percentage of patients offered navigation. So this would be the cancer patients that are inclusive of analytic cases. So those that are new diagnosed primaries, reoccurrences, advanced diseases, metastatic of defined cancer sites within your program setting. So the American College of Surgeons Commission on Cancer has the, it's not so new now, but it will be that COC standard 3.1 on patient navigation. And it's really that a patient navigation process is to be established to address barriers to care for patients with cancer and healthcare disparities, either on-site or by referral. I think the key word in this Assessment Area 6, though, is the percentage of patients offered navigation. So really making sure that all of our patients know that we're available to them. Not all of our patients are going to need navigation. Not all of our patients are going to want our assistance, but making sure that it's available to them. It's also important to note in that standard that it really is that there is a process in place. It doesn't define that there has to be a person. It doesn't define that it has to be a specific type of person, but that you have a process in place in which your patients are able to be navigated. And then standards are developed to address really the disparities to care, so those patients that aren't getting the care that they need, and then the barriers to care, those things that keep patients from getting the care that they need. In this Assessment Area 6, it really offers the means to monitor progress toward that standard. So as we begin, it begins with a percentage. So 0 to 20% of our patients defined in a tumor site, all the way up to greater than 80%. And so looking at that. And some of these measures, as you go through them, really, if you have more than one disease site that you're focusing on, you may need to look at some of these measures individually within that disease site, and then your program as a whole. Sorry, I'm losing all of my slides. Let's try this again. And then in Assessment Area 7, in that continuum of care, so the functional areas along the continuum. So where are we navigating our patients? So those areas such as outreach and screening, abnormal finding and diagnosis, treatment, survivorship, and end-of-life care. In some programs, we may find that a navigator is responsible for all of these areas. They take their patient from the outreach and screening all the way through to that end-of-life care or into survivorship. In other institutions or healthcare systems, we may find that a navigator functions in one area. So in our facility, we have our breast navigators pick up patients at point of diagnosis. We have an excellent imaging system. We have nurses within the imaging area that work with those patients specifically, and then there's a handoff to our navigators. Where other systems, you will find that breast navigators pick up their patients at point of suspicious finding and carry them all the way through. Sometimes we begin in a functional area and then grow to include other areas as they're able to. I think we always say start small, but dream big. So beginning with what you can manage in the beginning, knowing that you're going to have growth, and then add other areas as that continues. And then looking at Assessment Area 8 within support services, support for potential needs should be available through Navigator referral to support services. So we look once again at our hospital-based resources, what we have available, what's available to our inpatients versus our outpatients, and then our community-based resources. So as we look at that inpatient versus outpatient piece, what we found is that we had a great referral system for patients that needed nutrition services within our inpatient area. We did not have it as developed within the outpatient area. And so that was something that we were able to kind of work on so that we could get our patients referred when they were outpatient as well. And then looking at those things that are community-based resources. The one thing that we don't really need to do is we don't need to recreate the wheel. There's a lot of great organizations that offer services and offer support services for no cost that would be of great value to your patients. And so as you're beginning a program, one thing that many hospitals start is a buddy program, and that is fantastic. And if you have the staff to support that and you have the patient survivorship population to support that, that's something I'd greatly encourage. But doing that in the beginning of a program is very difficult. And so there's great organizations out there that are buddy programs that can be available to your patients. Looking at those organizations that target the subpopulations that may be a little bit more difficult for a hospital system or institution to do. So looking at our young adult population, organizations like Stupid Cancer and the Young Survival Coalition for our breast population, they're fantastic organizations that we can use for referrals. Also, it highlights the importance of advocacy role for navigation. So as I said before, really identifying those areas of need. We identified that there was a need for outpatient services within the nutrition area. And then also helps us to connect with all members of the multidisciplinary team, just informing them about what support services are available for their patients. There are resources that are available that some of them were not even aware were available to them. And then looking at Assessment Area 9 within the reporting tools. So reporting and documenting navigation data is essential. And I can't stress that enough. It is very difficult, and sometimes that's a piece that we don't think of, but when we hire navigators, we need to ensure that they have a way in which to document. And one of the things that I would highly recommend is that this is something that you work through also with your legal team, because you can't have a nurse just kind of in an outpatient office somewhere documenting on paper, just sticking those papers in her desk drawer. Those have to, we've got to have those within patient charts. They've got to be in the patient record. And so really working through what your needs are. And so within our tool, we looked at just kind of that paper charting or that Excel spreadsheet all the way up to reporting through an EMR, through a patient EMR. So some of us are fortunate enough to have an EMR system that will cover us, and the navigators can begin documenting in there. There are homegrown systems that hospitals sometimes develop. But all of those pieces, we need to make sure that, one, we are following our nursing practice acts, our hospital policies, our state policies for documentation of patient information, and then two, that we're doing that in a way that is secure. So making sure that if you're going to use an Access database or you're going to use an Excel spreadsheet, that Excel spreadsheet is not contained on a server that's readily available to anyone with patient names and information. So thinking through those pieces. We use here a EMR system that is actually a case management system and has a module to it that we have kind of done some work to make it fit our navigation needs. And then moving through to Assessment Area 10, which is the financial assessment. So financial difficulty is a barrier that patients frequently report, and it keeps patients from getting the care that they need. And so we're looking at that increased cost of medical care and treatment, the loss of wages for the patient and the caregiver, and then the accumulated effect of long-term illness. It really does affect patients' decision to seek or continue treatment. think I read a statistic the other day that 1/3 of patients, that was a factor in the treatment that they were receiving. And so as we start looking at our tool, we're really looking at, do we offer any kind of financial screening for patients, and then all the way up through that we're offering proactive financial assessment and counseling, and then documenting that and doing that quality improvement measure. There are some excellent tools out there. The ACCC has a financial advocacy network that has a lot of resources and tools for the multidisciplinary team. If you haven't looked at that, I would encourage you to, because there's a lot of things there that will be very useful for your team. In addition, the Oncology Roundtable offers quite a bit of recent blogs and literature around just financial navigation and doing that proactive piece of proactively helping our patients get the assistance that they need prior to beginning treatment. And then Assessment Area 11, that focus on the disparate population. So looking at those disparities that are within your area. So any underrepresented group that your institution is able to focus on is considered that disparate population. We know that there's higher cancer death rates in those who live in poverty, as well as certain ethnic and racial groups. And so really looking at what those are and how we can assist them. And then providing outreach and effort in this population really is a hallmark of navigation. So as we begin our tool, we're really looking at that level 1 as none defined. We really are just not focusing on the disparate piece. And then all the way up through 5, where we're looking at cultural sensitivity assessment that's completed on our center staff, and that we create those cultural objectives on at least an annual basis. The U.S. Department of Health and Human Services does a cultural competence website and has a lot of great resources. And they're at that www.hrsa.gov site, and you can go there and look at some of their cultural competence pieces, but something that we definitely want to consider moving forward. And then as we look at our Assessment Area 12, really navigator responsibilities. So a clear definition of the scope of the navigator needed. We want to help focus efforts. We want to resolve conflict, and we want to avoid burnout and unrealistic demands. One phrase that I get in trouble from my supervisor for, but I do use, is that navigation is not the answer to bad process. So for people who frequently have to justify their positions, we seem to be the answer to a lot of people's problems. Well, we'll just have the navigator do that. And the problem is that as we do that, we lose the focus on the patients, and we get more and more scattered. So the Oncology Roundtable did a study in 2010 of navigators and found that 50% of them reported that they had 8 or more major responsibilities. When you get that many responsibilities, the chances are that you're going to make mistakes, or that you're not going to be able to give the attention that patients deserve. And so we want to just avoid burnout of our navigators as they're running from here to there to do this or to do that. So just looking carefully at what their roles and responsibilities are. And I think that, once again, this ties back to where having someone with oversight of navigation and a clear supervisor is very helpful to kind of help define what those roles should be. Assessment Area 13 is patient identification. So looking at how we're identifying our patients. So in our matrix, we looked at level 1 as no formal patient identification. So you're getting your patients through a variety of ways. And then all the way up through level 5, which is our primary care provider and or specialist refers at the time of abnormal finding. I think this area in particular on the matrix is kind of a moving target, because I will find in some disease sites we're always getting the referrals from those specialists, while in another disease site it may be inconsistent. Yes, sometimes we do get the referral, sometimes we don't. Sometimes we're still having to identify those patients through path reports or through hospital census reports. Assessment Area 14, so looking at navigator training. So successful implementation of navigation really is dependent on training. And so we need to look at our in-house training. This is more than just doing, a clinical checkoff list or a simple job sheet. It's really having them know the systems of the hospital, know how patients move through the systems in both the inpatient and the outpatient side, looking at competencies that work for them. And so really that kind of moves into our recognition of the core competencies. The National Coalition of Oncology Nurse Navigators started with those initial core competencies. The Oncology Nursing Society has done a fantastic job and has just released the core competencies for nurse navigators. And I know that George Washington University is currently working on that lay navigation competency piece. And those are what we need, those things which will help us determine the training that is needed to help navigators be successful in the role that they're doing. At our institution, in that initial 3 to 4 months, we've picked 8 areas that we feel the navigator has to be functional and competent in, and we focus on those and those alone. And then we add other pieces as we go, but it's just those core pieces. So we look at understanding the professional role of the navigator and of the team itself, looking at disease-specific care, so whatever area that they're going to be working in, that they understand that. Looking at some key areas in oncology care that are focuses for our system and our hospital, which for us is clinical trials and smoking cessation. So we do advanced training in there. Looking at the cultural competence and the health literacy piece, documentation is key for us, so we spend time working on the documentation and training. Person-centered care. And then really, probably the area that I really think has been very helpful for our navigators is managing change, because every day there's change within the role, there's change in what we're asked to do, and so they do work within that as an initial competency. And then assessment area 15, our engagement with clinical trials. So navigation plays a critical role in clinical trial education, empowering patients to take an active role in their health care. And so what you'll find in navigation is really a range. So there are those that are providing basic education, which is what we do at our center. We do basic understanding of clinical trials with patients. We do that basic education with them about what a clinical trial is, how to access our clinical trial registries, how to reach the number to talk to our clinical trial employees, and then all the way up to the navigator engaging with the research team and assisting with specific clinical trial referrals for underserved population. I know in Spartansburg, one of our sites, their navigators had great success in really pairing up a navigator and a clinical trial nurse, and they had a great impact on increasing clinical trial engagement. And then looking at that assessment area number 16, which was the multidisciplinary conference involvement. So that conference is integral to the care of the oncology patient, and our navigators should be invested in that and should be participating in that. So, our basic level is really that our navigators are there. They're listening to the discussion, and then really moving up to that level 5, where they talk about patients being informed of the presentation of the MDC with full formal report on treatment. And there's a discussion with the physician. And I will tell you that within our facility, we will never be a level 5, because that's not something that our physicians want to do. They don't want to release that full formal report. So that for us is not an area that we're going to aspire to a 5. But we do, we're at a level 3 and we're comfortable with that. We're also not comfortable. The level 4 is really that the navigator's providing a formal review with the patient and going over those results from the tumor board. We're not going to do that as well. So we really assist in the case finding. We do go ahead and offer input within the conferences of what navigational needs the patients have. And then we also assist with getting those treatment recommendations recorded and then back to our physicians so they can follow up with patients. So I think that brings us to the end of the assessment piece, and I'm going to turn this back over to Peggy.
Okay, the next couple slides, and I'm not going to go over them point by point, are the actual navigation assessment tool, where it goes from what is level 1 to level 5, and you will have that in your handouts. This slide you already saw, but I'm going to give you some examples when we looked at our system and our patient populations and how it can vary. When we did the assessment tool at the percentage of patients navigated, the level 5 is like 90%. When you look at our breast patients, we probably are hitting 90% of our patients. When you look at our head and neck, we're probably, with anyone having multimodality, hitting 90%. When we looked at our leukemias, there is no way that one navigator could do 90% of the hematology patients. What she did is she developed an acuity system where she found 5 items that went across all of the hematology that she saw as core indicators that patients probably were at high risk. So she navigates those patients for sure. She's available for any other patient who might be identified as high risk by her champion. The other thing she has been able to show with her core measures of those 5 indicators is that she has decreased readmissions to the hospital. So she kind of looked at her patient population and knew she couldn't do them all. She looked at the system and knew that there is no way we could hire more people. And then she looked at what were the big things in her area. One of the other things Kathleen talked about is we may not all hit level 5 on things. One of the things we had done as a whole system through the NCCCPs is we looked at the navigators' engagement with clinical trials. And what that really showed is the navigators thought they were pretty high up there, 4s and 5s. When you actually talk to the clinical trials nurses, they had a different feel on where we were. And part of the reason is how our system works. I know at our system, our navigators know what trials their patients are eligible for. I know that they are familiar with the trials. They may talk informally with the patients about the trials. They may talk to the primary care physician about the trial. But on the matrix, it says who does the actual referral to clinical trials. And the navigators feel they play a major role in that. But the actual referral is made by the physician. So from the clinical trials nurse's point of view, navigators do nothing with clinical trials for referrals. So it's kind of talking to who your stakeholders are and making sure you have a clear identification of what your goals are. So what did we find out as the NCCCP programs doing the self-assessment tool? We found out that all the programs in the NCCCP saw expansion. Most of us started at a level 1 or 2, and most of us progressed to 3 or 4 in some of the areas and a 5 in other areas, depending upon what the goals of our programs were. The areas that improved the least but probably needed the most improvement were developing an acuity system. For areas that probably have one navigator, such as your breast navigator, you can pretty well have one-size-fits-all acuity system. When you start having a head and neck navigator, a leukemia navigator, a thoracic navigator, a colon navigator, their acuity systems are going to be different. How many patients they can handle is going to be different. And that was one of the problems that most of the groups found across the board, was trying to find something that worked for everyone. Quality improvement was another one that we did not improve as much as we wanted, because most of us wanted to identify measures that showed sustainability. We could show that patients were happier, that we kept patients in our system because of the fact they had navigation, and we may have kept them out of the hospital, but we are not a billable service. Reporting tools was another issue that most of us did not get to a level 5, because most are homegrown. Most of them don't talk with the current EMRs, so that was really a problem. Another big one is, depending upon how many navigators you have in your system, most navigators are trained on the job. When you hire a new navigator, you're either replacing a navigator you had in the past, or you're developing a new position, usually in a different area, and each disease site is going to be different with what they can do, how they're going to access care, how they're going to evaluate patients, and which patients will be navigated. One of the nice things, and at the time that we were doing our matrix, we didn't have most of the core competencies developed. I think that is going to make a difference for moving forward in the future for all of us. So once again, while the aim of 5 should be in some of the assessment areas, we're not going to be able to do it in all the areas depending upon what your program has, what kind of support, your finances. So it's really a growth tool to see how your program is going, identifying areas where you may improve, and following up there. This project, just so you know, was funded in part from the National Cancer Institute. We can't endorse trade names commercials. And I guess we are now to the question part.
Thank you so much, Peggy and Kathleen. That's wonderful, and this is such an amazing tool. We do have a few questions that came in through the chat that we'll try to address those first before we open it up. And again, for all the participants, if you have any questions, go ahead and use the question and answer box on the bottom right of your screen, and we will do our best to make sure we communicate those questions. The first thing is that they were asking, participants were asking if you could repeat the websites for the financial help for patients, which we think was on the ACCC website.
It is.
And, yep, go ahead.
Sorry. It is, if you go just to the ACCC website, there's a financial advocacy link, and it's called the Financial Advocacy Network.
Okay, and we will look for that, and we will try to post it right here in the chat box for everyone. And the other link they were requesting was the the cultural disparities competencies, which I think you had mentioned was on HRSA website, but we wanted to double check.
Yes, so it's www.hrsa.gov, and then it's /cultural competence.
Great, thank you so much. Now we did see this, the participants were kind of answering their own questions, and they were kind of starting to chat, and I don't know if you get to see this, but they were asking if patients' families can attend multidisciplinary meetings with their patients, and can they take notes, ask questions, and what are your thoughts on that?
Peggy, I'm not sure what Peggy does at our center. At our institution, that is not a possibility. The physicians are happy to sit down with the patients and the families afterward to have that question and answer period, but those tumor boards are closed sessions since we're also presenting other patients and their information.
Our system is pretty much the same. The MDCs are not, they're multiple patients. Our probably closest to the exception is breast, because we do offer for patients that are newly diagnosed the opportunity to meet with the surgeon, medical oncologist, and radiation oncologist. We run a clinic twice a week where they can see all three at one time, and their case is a little bit discussed among the family and the patients and the 3 doctors at that time. But the actual MDC conference, our patients are not allowed to come to.
Okay, thank you so much. And I'm going to give participants a few more minutes because we want to be respectful to everyone's time. If you have any last-minute questions that you would like to have Peggy or Kathleen answer, and I'm getting a few. Okay, I think they're just still kind of chatting about different settings and whether or not that's appropriate. We've added the links to go ahead here in the webinar, and we will make sure to add those to the slides and or the presentation or the email when we send them out to make sure that everyone does get that. So I think that's it. We'll go ahead and, oh wait, we're getting just a few more questions. Give me 1 second. As people are typing away. And again, this is definitely an amazing tool, and we're very excited to have you both having presented on it. And we're looking forward to more opportunities where we can share your success stories and or any other stories that you would like to share with everyone here in the field. Let me see here. Okay. So I have a question. It says, do you have any comments about institutions where there are nurse and lay navigators and how they can effectively collaborate? And I know Kathleen and I were talking about this earlier, so if you have any thoughts.
We have both nurse navigators and lay navigators at our institution, and I have to say, when I started in navigation in 2006, I thought it was a job for nurses because I'm a nurse. I thought we needed to do it. Over this last 8 years, I have seen the value of having multiple people on the team. So our team now is comprised of lay navigators, nurse navigators. I have an oncology social worker that functions in navigation, and we're actually getting ready to add a physician assistant to our team. And so I think that it works very well. I think that there are things that nurses are doing that nurses don't need to be doing. We don't need to have nurses doing data entry. That doesn't make a lot of sense for the training that we've had. What we've found in our institution is our nurse navigators function very heavily in the education role, coordination, the multidisciplinary conferences, tracking the patients and seeing them. Our lay navigators really help us with the patient empowerment piece. So they're helping patients get organized, getting them to resources. They're heavily in the resource end of things. Anybody that's done navigation knows how long it takes to arrange transportation or, to get utilities turned back on. And so our lay navigators are assisting with those types of things. It has been a tremendous experience for us. We continue to add to our team. We started in 2010, and there were 3 navigators and myself. By the end of fiscal year 2015, we'll have 32 team members. So I think we're setting it up really with role delineation, making sure that roles don't cross so that we can continue to add to our numbers and be successful in navigating our patients.
Okay, that's wonderful. And I'm going to go ahead and just, I'm looking at time, but we do have some questions coming in. The first one I'm going to have is, does the COC provide any information about how many patients, let me see here, we should receive navigation services to meet the new standard?
The standard really just says that navigation has to be available. So what we've done is work toward making sure that our 100% of our patients know that navigation is here and it's available to them.
Great. And let me see, what types of certification are available for navigators and where? Do you have a strong preference?
I think the only 2 I'm aware of are for breast, and one is through the NAPBC, and then there's a breast one through ONS.
Okay, right.
And I want to go back to the, this is Peggy, on the lay navigator and the nurse navigator. We have both too. I think the big thing is you have to have clear role delineation of what one does versus the other.
Agree.
Okay, no, this is great, and again, we're trying to be respectful of everyone's time. So we did have an influx of questions, so we're going to go ahead and ask everyone to continue this discussion. We will jot down all of these questions, and we will have Kathleen and Peggy answer them for us, and we will be posting the answers to this discussion on our LinkedIn page. So we're going to go ahead and put our link to our LinkedIn page, and we would love for everyone to join the discussion for the webinar after this and make sure that we answer all of these questions. And we do definitely have more information regarding COC standards and some of these certification questions and whatnot that we would love to provide. So moving forward, I just want to bring your attention again to all of our CA SNAP resources that are available. I want to take the time to thank you both, Peggy and Kathleen, for sharing your expertise, and to our participants for joining us for today's webinar. Again, a friendly reminder that following this webinar, you will receive an email with the recording and today's slides, and you will be also automatically redirected to an evaluation, and we would love to hear from you to make sure that we are doing our best to meet your needs in this webinar as well as in our future webinars. So Thank you again. We will provide the answers to your questions on our LinkedIn page. Definitely check us out on Twitter as well. And we hope that all of you have a wonderful and safe Thanksgiving holiday. Thank you.